Bola Ahmed Tinubu, he made a commitment to health and said, these are the targets I want to achieve during my tenure in health. And he appointed a coordinating minister of health and social welfare, and that the idea of that was to see that health is not just happening alone, but it's also inclusive. And most times, things that have to do with inclusiveness are considered like social welfare things. Making sure women are inclusive, making sure youths are inclusive, making sure that the people that have various forms of disabilities or inabilities are inclusive. So he's the coordinating minister, so has that purview. So in trying to make the president's commitment come true, he said, you know, we can do it. He said, we have a single plan that everybody working within the sector, be it government, be it national, be it state, be it partners, be it donors, be it consultants, be it pressure groups, advocacy groups, we must have one plan, and then everybody can use their resources to implement that plan. That is what the swap is all about. It's called the sector-wide approach. So everybody within the sector agrees on what is the most important thing we must address, and then everybody that has resources targets their resources to addressing that. It does not mean everybody puts all the money in one bank account, but everybody's just working towards the same goal. So in doing that, that is how we are trying to ensure that we actually address the poorest population. Because first, monies that could have gone in different directions doing likely the same thing is all now viewed as one pool and targeted to the priority. And for that to happen, based on presidential commitment, the swap is being implemented through a strategy we call the Nigerian Health Sector Renewal Investment Initiative. So this initiative, the word investment is important, because even though we know health is a right, most times nobody's paying attention to actually invest in health. Hence that word is there. So with all the funds in the right pool, and the key word in that strategy, if you Google and see it, you'll see it's written on top there, to save lives and reduce pain from health-related conditions. And who are those that feel it the most is the most vulnerable, right? That is why that is really important. So the fund is together, we can target the vulnerable. We have one plan that prioritizes saving lives and reducing pain, which targets the most vulnerable. And the most important is that we now use a lot of data evidence to take decisions. So not just that, oh, we have money, people are ill, go and treat them. We look at the data, where's the illnesses more, where do they need the most intervention, what are the interventions required there, and that is used to do that. And because of that, one of the main things we're doing, I'll round up now, sorry, I have to give that kind of background looking at our audience so that they can follow the conversation, so please apologize for taking an extra minute. One of the main things we've even done is that, because part of the strategy at the primary care level, which is managed by the MPACDA, is now to make sure we revitalize primary care centers and make them functional. So we have taken the baseline of the centers that receive money from the Basic Care Provision Fund. We now know their status, and we're working with the states that have the bulk of the money for revitalization to make sure that the right center that requires the right intervention is what is getting. We're using data in that way, right? And we're also ensuring now, because of the swap, that there's some transparency in who has money, where is the money, and what the money is being used for. Even our partners, because before now we wouldn't know where the money is and where it's going. But now even government has to tell the partners have to tell the government this is the money we have. So that transparency is improving the investment. But more importantly is the insurance, which is happening through the National Health Insurance Scheme that is being expanded on that swap, because there are more resources coming in to cover the way we call it, cover lives and all of that. And the money that is coming from the BSPF to the facility, all that is being used to ensure we improve quality of care and that we reach the reachable. So I'll just pause there for now. Thank you.
Thank you so much, Dr. Ogbe, for that overview. I'm sure a lot of our audience is now, they understand SWAP better. And you mentioned something about the BHCPF, the MPACDA gateway, also leveraging the SWAP to revitalize the primary healthcare centers and identifying those who are really vulnerable so we can focus on them. But Dr. Gafar, let me quickly ask you, with all this money that we are going to get from various partners, donors, government, and everything in one basket, how are we going to ensure equity and efficiency in the utilization of those funds?
Okay, thank you very much, Nena, and good morning, everyone. And first and foremost, let me thank and congratulate the organizer of this very, very important event for the job well done. Gender and inclusion is very central to achieving universal coverage, which some of us are very, very passionate about. Before answering a question of efficiency equity asked by Nena, I think it's very important to set the stage and to acquaint us with where we are in the global sphere with regards to universal health coverage. We have a lot to do. And if you look at the most important indicator used to gauge mileage of universal health coverage, they call it the Universal Coverage Index, which is a global index given a score to each country. Nigerian score, out of possible maximum of 100, is only 38 in terms of universal coverage index. But if you look at sub-Saharan Africa, of a group of very poor countries, their average is almost 50, sub-Saharan Africa. Now, while one of the most major reasons why we have actually not made progress is because our health system delivery is not inclusive enough. It's leaving behind the poor and the vulnerable people, which is very, very, very important because in Nigeria, it shows that if you have money, you have access to almost any type of care you have. But if you don't, you are actually deprived. So that set the stage in terms of where we are in this sphere of things generally. So with regards to how do we ensure efficiency, how we ensure equity, there are two big questions. And I would like to start with the efficiency part of it. Nigerian health system is highly inefficient. And if you look at across parameters, and I will give you an example. If you look at our human resources for health, and I'm using human resources for health because that is where the bulk of money on health is actually going to, government money. An average state in Nigeria spends almost 70% of health spending on human resources for health. And this is where we have a lot of inefficiency, like I talk about, a lot of issues around ghost workers, around a lot of absenteeism, to the extent that there is even a phenomenon called organized absenteeism now. We are in a particular facility, there are 15 health workers. Maybe there will be an arrangement, only 2 will be working, the rest will be away for the next few weeks. So we are wasting a lot of money in all aspects. I'm just using human resources. In terms of productivity, a survey done in Africa shows that an average health worker in Nigeria is far less productive. Maybe sees an average of 3 or 4 patients. Of course, it varies from facility to, but it is average. But when you see a country like Tanzania, they see more than 12 and all those. So there are a lot of ways where we waste our resources in the health sector, and even putting a health facility where they are not needed, and where they are needed, they are not there, and all those stuff. Maybe prescription for non-prescription of generic drugs, which could be cheaper and save us money and everything like that. And then the issue of equity, of course, is well established in terms of who is able to receive care. So it's well established that an average, if you look at the wealth quanta in Nigeria, the richest class, they are 5 times likely, they are women there, likely to deliver in health facility than the poor woman in Nigeria. But maybe enough of lamentation, let's open the book of a solution. So in terms of what could be done, I think Dr. Ogbe has spoke to some of them in terms of leveraging SWAP as much as possible. SWAP will provide opportunity to ensure coordination so that there is reduce the overlap in spending and all those stuff like that, to strengthen coordination as much as possible. But at the same time, we need to put systems in place to ensure we are tracking resources. Happy budget is here. They have been doing a lot of great work in terms of following the money, ensuring we're able to track what the money is spent on. But at the same time, we need to leverage technology. There is an example of Gombe State where they have introduced biometric attendance tracking, where they have been able to discover a lot of ghost workers. They've been able to discover those that are not ghosts, but are not working in the state. They've discovered that those that will come and go and all those stuff like that. So we need to deploy technology. Another area which is important, we have to look at, we have seen the example in Lagos State. Lagos is doing what they call, the governor has given a standing order for exit replacement of exiting workers. We know this is the era of Japa syndrome, where people are living. But the unfortunate thing about Japa is that apart from creating gap in service delivery, is also a room for a lot of wastages as well. Do you know that when people leave, when they die and all those stuff, the money is still leaving the cover of the government. So what the governor has done is that, and you know the bureaucratic challenges around recruitment. What the governor has done is to ensure that there is a standing order for replacement. Any health worker that leaves today must be replaced in time. So coming back to the equity, I think there are a number of existing policy trusts as well. Dr. Ogwe talked about basic care provision fund. But at the state level, almost all the states in Nigeria, they have state health insurance legal framework that actually introduces like 1%, that mirrors what's happening at the national level, introducing 1% basic care provision fund. At the last count, maybe less than 10 states actually funding this basic care equity fund. So we have a role to play, all of us as civil society, to track who is releasing the money, but it's not enough for the money to be released. We have to track to ensure that it is actually those that need the money that are benefiting from equity fund. So one ideal thing to do is to go and look at the social register and identify who are the poor and vulnerable, and select them, enroll them. But the social register itself, there are a lot of challenges as well. Somebody was telling me in the social register in the States, they found the name of the mother of the Speaker of the House of Assembly, and I'm wondering how vulnerable that one could be. So we have to look at that as well in terms of equity. But before I go, on this issue of equity, if you look at amount of money available today, basic care provision fund, equity fund, put everything together, and considering the size of the poor and the vulnerable, it's like I won't call it a drop in the ocean, but we still have a long way to go. So people are talking about how do we mobilize funds from like innovative resources. A lot of analysis have been done. I think we just want to ensure there's a political will to pursue those innovative means so that we mobilize additional funds, and we ensure these funds are actually going to people, and we are tracking, doing benefit incidence analysis to know who's benefiting. I would like to pause here for now. Thank you.
Thank you so much, Dr. Gaffa. Thank you. And as he was listing all these things, he was also giving us some solutions, which brings me to budget. I mean, Dr. Gaffa mentioned tracking the money. How do you plan to evaluate SWAP? How do we know it's working? How are you going to track the money and make sure it gets to affect the lives of the common man on the streets? Let's hear from you.
Thank you very much. Good morning, everyone. And I think Dr. Gaffa has done a bit of justice to that topic. And when we talk about effectiveness, I think the key point that we'll have to pay attention to is data. And I mean, we work with data, and data, they say, don't lie, right? Particularly when we talk about the marginalized group, there is an increasing demand for us to be able to have an accurate record of who are the marginalized group in our population, who are those that fall into this group. I mean, there is an instance Dr. Gaffa mentioned of, when you have opportunity to look at the register. I mean, we have also seen the register. Sometimes you just try to Google some names, find some names, and then you are seeing some names and you are asking yourself, are these really the people that really need a conditional cash transfer or need this sort of subsidy from government? Can you hear me? Is this working?
It's working. Oh. Can't hear him. Try this one.
All right. Yeah, I think this is better. Yes. So data is very important for us to be able to understand the number and the that we are dealing with when we are talking about marginalized group. Then beyond that is also having an assessment of what are the needs of this group. And understanding that when different states in Nigeria have different contexts, even within the states, there are different, contexts within local governments, within communities. How are we ensuring that in the distribution of resources, the available resources, we are distributing the resources in a way that speaks to where the needs really are, right? You'll find a situation where there are PHCs in a, so to say, metropolitan city within a state that if you put the same level of resources in that PHC as well as you put in a PHC that is in a rural community, the number of needs that they are attending to is quite different, right? In this PHC that is in a metropolitan city, is such that majority of the people there can afford the services. They can even afford to go to a private healthcare. And then when you go to a PHC that is in a rural community, you find that particular PHC attending to quite a number of people that fall within the bracket of a marginalized group. And then the unequal distribution of resources then affect the effectiveness of SWAP and what we are trying to achieve. So I would say baseline is very important, but beyond baseline is that we need to embrace the involvement, inclusion of the marginalized group themselves in this process, right? Because involving them then make it easy to, number one, market the initiative, market the ideas of government. If someone has gone to a facility and he has been well attended to, there is more likelihood for that person to be able to preach and inform another person that cannot afford that service to go to a particular healthcare center. And this is what we have seen. We have the privilege of working, in the grassroots community, and we have seen that works out where once there is a sort of improvement in service delivery, people in the community tend to tell themselves, right? And what we have seen in SWAP is beautiful. Dr. Ogwe, narrated it. It's beautiful. We need to start, even talking about data, we also need to start from who is doing what. Where is the central plan? And in all of this, we will not do away with technology. Technology will allow us to be able to see the overall goal that we want to achieve as a nation. Will help us to see who is doing what where, and then will help us to be able to hold ourselves accountable. And not just government, holding government accountable now. There are private sector, there are development partners, there are civil society organizations, there are different entities that is contributing to the overall SWAP agenda. When we have it well spelled out in a publicly accessible domain, it helps us to know who is contributing what, who is meant to do what, right? And by so doing, we'll be able to hold ourselves accountable and effectiveness will improve.
Thank you so much. Please, a round of applause for him. Thank you. So I hear lots of things. I hear data is key. We must leverage technology. We must also involve the marginalized groups because we can't do anything for them without them. And again, I'm also hearing that we need to break down this SWAP and know who is supposed to do what and how much is coming in and what is that money going to be used for so that we can track it. Thank you so much. And that brings me, CCT has been mentioned, getting money across to these people that are marginalized. So my question goes to Fejiro. Controlled cash, this conditional cash transfer, sorry, thank you. Conditional cash transfers. We've talked about the social register. There are so many problems with it, yet we know it has been used for conditional cash transfers. In your own estimation or your experience, has it been successful so far? If not, what are the challenges and how do we move forward?
Thank you for that question. Good morning, everyone. Okay, so just set a context and define conditional cash transfer because of the audience. I'm just following the cue from my other panelists. It's a program where health-seeking behavior is rewarded by financial incentives. So different countries have used it, have tested it to improve the health outcomes in the country. There are case studies of countries like Brazil, Mexico, where programs have been initiated with this CCT as a model for the program. And they saw really good data on uptake of vaccines, so vaccination rates, reduction of malnutrition, and then increase of family planning usage and overall health utilization. Even in Nigeria, I know that there is the National Social Safety Net has a program where they have that conditional cash transfer. And studies have shown a 13% increment in ANC visits where that has been instituted. So my co-panelist said, data doesn't lie. So it means that there is a use for CCT. There is a use for it at an early stage, so a short-term project, a short-term implementation, a short-term method for a long-term gain. However, with everything that has pros, it has the cons. So you've mentioned one rightfully, which is who are the target audience. So if we're using this Nigeria social register, we should start from there. Is there targeting? Are we really targeting the vulnerable group? How can we make the social register smarter? And there are several ways. All of us, the majority of us have registered for our national ID cards. Majority of us have BVN. So there are ways to synchronize data in Nigeria and to come up with a social register that would definitely target the vulnerable. So the first thing is really, can CCT be disposed or used for the target group, which is meant for, which is the vulnerable group. Secondly is the monitoring. So targeting first on the group, also targeting is for the health behavior. So CCT must have a targeted health intervention. It cannot just be left broad, it must be very specific. So it's specific, such as maybe ANC visits, very specific reward for a specific intervention. Secondly is monitoring. We have to monitor, like you said, who got the disbursement and how, and was it just someone ticking? Because we have, from a program implementation part, we know that data doesn't always lie, but data can lie because somebody else is collecting the data. A human being that has flaws is collecting that data. So there must be monitoring, external monitoring. There is also the part where CCT must have a long-term complementary service, which is health education, so that you can bring them in with financial incentives, but the curve shows that financial incentives would get to its peak and it would die down. So after a while, people are going to throw your money back at you, or they're going to ask for more money, or they're going to ask for more, and you can't keep giving more and more. So from the very onset, what are the complementary services that we go with CCT, such as health education? Another thing is also research, because most times we always talking to the beneficiaries and not listening from their point of view, what is causing the poor health-seeking behavior. And secondly, another complementary service that we must have for CCT is that...
Hi everyone, good morning. My question is, how can AI be leveraged to close the gender gap in various industries? So I know that we've been talking about
I think we have some
AI,
interference.
So how can we leverage on that to close the gender gap?
Tech team, please, can you? Okay, thank you. Please.
Thank you.
You can round up.
So another complementary service we must have is a complementary service where we also reward the health workers. Because if we're just rewarding healthy behavior, so that's the performance-based financing. If we're only rewarding, we'll know that the health workers will frustrate the program. So there is always the supply and the demand side. Exactly. Another thing is also the quality of care. Most people don't see, you will not buy what you don't want, what you don't need. You only buy what you need, and yet we know that people drink Coke every day. Not because they know that they need Coke, even when they know that, sorry if I'm reducing any brand, even when they know that fizzy drink has a lot of sugar, they buy it. Why? Because they have been branded to see that they need it. So if health has not been branded to see that they need it. So we did a research sometime on with our youth campaign, and they said even for things like HIV, that connotation where HIV doesn't have cure is a deterrent to screening. That can it be branded? So we are not branding health in a way that is encouraging for anyone, so that when that CCT wins, when it gets to a peak, when it's in a decline, we can layer on that. And lastly, what I would say to that is then that we must have quality service delivery. If a patient comes, even after giving money, and they lose their baby in delivery, they won't come again.
Thank you so much. A round of applause for her, please. Thank you. So CCTs, they are effective. She says they're better in the short term. We should focus on targeting. We should focus on targeting as well. So we've had some of the challenges and some of the benefits. Dr. Gafar, very quickly, should we be thinking of scaling up CCTs? What is your opinion?
Okay, thank you very much. I think, again, before answering that question, don't let us forget that conditional cash transfer is a vehicle for delivering resources to buy services. And there are other vehicles as well. There are health insurance and all those stuff. I think what is important is to look at the source of the money. in terms of the volume of the resources and the sustainability of that. Okay. If it is a public money that will be there for a long time and all those stuff that is financing CCT, fine. But the challenge here is that one donor, World Bank here and all those stuff like that, put this money there for CCT, 3 years, the money dried up and all those stuff like that. So like my colleague here say, in principle, CCT makes a lot of sense.
Yes.
We have seen a lot of results, even locally, where it has been delivered and used to upscale services. Okay. My challenge is that what is the sustainability of the source of the funding that we are using it? Secondly, the second aspect is it's not only about having the money to buy the services, but there is this strategic purchasing element where you link money to services and the quality of services as well. Do we have the optimum mechanism within the CCT to be able to actually do the strategic purchasing where we are looking at the quality of service being delivered? I think in terms of scaling, my recommendation is that, of course, we can scale it as work and everything. But in the long term, I think we should be looking at the long-term mechanism of integrating this money into the health insurance as much as possible. Okay. Don't forget that most of the conditional cash transfer that you have, or the one that is not even conditional, people end up, look at most of the social investment transfer and everything. People eventually use the bulk of the money to access healthcare. Yes, so why can't we, in the long term, integrate with health insurance and learn from some of the important lessons, learn from CCT to modify how we design intervention.
Thank you very much, Dr. Gafar. Thank you. We're moving faster because of time. Quickly back to Mr. Gbenga here. Your question is, corruption is something that is multifaceted. We see it all over. And I'm sure the health sector is not immune. So what can we do about it from your perspective?
Do you have a mic there? All right. I mean, tackling corruption will come back to the conversation around transparency and accountability. And I make a distinction between the two. Transparency is that there must be a process, a system that shows what goes in and what goes out and how, by who. Accountability in the sense that entities responsible for managing resources must be ready to answer questions. If we are not ready to answer questions, there is no point being transparent in the first place. And when it comes to, I mean, we are playing very low when it comes to how much we need to invest in our health sector. So the little that we are investing, we must be able to create a system that makes it open, right? And to do that, it's simple. We have some programs that have worked in Nigeria before. One of it is what we call the State Fiscal Transparency and Accountability, led by, it was a World Bank project to states, and it was a disbursements-linked indicator, right? There are a set of indicators that states or entities that are managing our resources need to meet before a new tranche of disbursements is given to them. I think for the health sector, considering the bare need that we have, the very scarce resources that we are dealing with, we may need to work with a system like that. A system where before new disbursement is released to the states, there's also and then in dealing with corruption also, we must involve the people, the vulnerable group fund, right? We must involve them. And the systems are there, right? We have the WC system that government has already, facilitated in practically all the communities in Nigeria. Can we get them involved in the planning, in the reporting, so that, so that the community see what is going on, they put their signature to it, and then let it be on them too, that maybe they are also abating corruption to thrive in their community and undermine the efforts of government. But if we put all of these systems in place, maybe we'll be able to move the needle a bit further.
Okay, thank you so much. Please a round of applause for him. Thank you. Dr. Ogbe, we're going to be keeping it brief so that we'll have opportunity to take some questions if possible. How does MPACDA plan to really target the informal sector? We had something about targeting. How do we really want to focus and make sure that these primary health care services are available for people in the informal sector, a lot of whom are vulnerable? Briefly, please.
Yes, thank you very much for that. I think the informal sector are really those who are not like having 8 to 4 jobs or 9 to 5 jobs that are insured by their employers or by government to work for the public service. These are people who do their own business or unemployed, and they also need to be targeted. But most times in health, we actually consider more of the vulnerable groups in terms of those with, that are affected by poverty in a multidimensional way. So one of the things we really are doing there really are three key folds. One is that we are revitalizing primary health care centers, ensuring that where we have the most vulnerable people, the highest population are targeted, right? So that's one of the things. And working with the NHIA is also operating what they call the Vulnerable Group Fund. Now, this is a fund that is supposed to use things like the social register, which has just been talked about, but needs to be improved to actually see that the right people actually are the ones that are covered, and when they need care, they don't have to pay for it. So that's what the insurance coverage actually does. So the other way is also through working with the state insurance schemes and other and community-based organizations to have community health insurance schemes where people can come together in the community and either through the state insurance or on their own create a pool and pay some money on a routine basis, which becomes their premium, and they now register with the facility and pay monies so that they can have care. So the Basic Care Provision Fund, particularly when it comes to the one we're doing now, which is the reformed one to make it more inclusive and better, the 2.0, is actually looking at how the Vulnerable Group Fund can be upscaled, but this requires more investment. So money has to be spent to see that people are covered. Another thing that is being done, which will be of real interest to the audience, is really digitalization. So there's a big movement to digitalize health in Nigeria right now, inclusive of how people enroll for their insurance, how they get information about health, how they find where their facilities are, how they complain and bring back feedback from the community to those that are planning. And that's also a room where the young persons that are into tech can begin to explore that what are really the needs in health and how can we really intervene in that space, because as it goes more digital, there's more opportunity to interact and be inclusive, particularly for the young people.
Thank you.
Particularly one last thing we're also doing that is important to the audience, that in the coverage of services that are now under insurance, particularly in the informal sector, which the bulk of it are actually young persons, because most of the times they're unemployed and largely uncovered, which are things we need to really look into, is the fact that we're also ensuring now that there are a lot more coverage for sexual and reproductive health issues. Because as young people, one of the challenges you will have that will affect you more in a psychological manner is when you have sexual and reproductive health issues. So we have taken efforts of BSPF 2.2 that this is more inclusive, that more of those services are covered. We're going to train health workers to be able to provide those services in a confidential manner. And that, I think, we really target young people in making it more exclusive, not just for the vulnerable that are below poverty, to actually benefit for the BSPF 2.0.
Thank you. Thank you very much, Dr. So quickly to Fejiro now, let me quickly ask you, what is the role of the organized private sector? We've talked about technology, digitization, financing. What can the private sector do to help?
Okay, thank you. The private sector would definitely have a complementary input to what is happening in the health financing space. We know that the government is still the largest funder for health. We can't take away from that. But there is a role for the private sector. One is in the resources that they have. The private sector has expertise. They have resources in terms of health facility. They have resources in terms of healthcare worker. They have the expertise in terms of both the healthcare machines and all of that. The private sector can contribute that to the existing insurance scheme. So then this calls for public-private partnership, which the Lagos State has done really well, especially in the area of implementation, and not just funding or not just bringing funds, but an implementation of this health insurance. We know that one way that health insurance succeeds is in pooling of funds and not fragmentizing funds. And that's my worry with the several pockets of insurance in Nigeria. It's that if we pool enough funds, we would address more people. Secondly, is that the private sector can also contribute funds. However, little compared to the government, they can contribute funds because first they have a CSR budget that they have regularly for vulnerable people. They can invest into health investment funds, which would target the vulnerable people. They can also sponsor workers that are working under them in health insurance scheme and add to the pool. So there is the financial bit for it, but we must make sure that we are complementing each other. We are not working in silos, because then our target audience that will benefit, our beneficiary, will be very little, and we would not be able to sustain it over time. So I would love to hear from the NPACDA what the plan is to roll out this PPP nationwide, like Lagos State is doing.
Okay, thank you so much. I'm sure we'll facilitate that conversation. Please, a round of applause for our panelists. Because of time, I think we can take just one or two questions briefly before we wrap up. Any questions? There's one hand up, okay, and two. Just take two. Very briefly, please. The tech team, we have extra microphones that we can. 1 minute. Do we do three? We said time has such a... Okay.
We know that there is limited resources.
Yes.
So how do we balance trying to improve access and also knowing that we have... Thank you. How do we balance improved access, equity for the vulnerable population, just knowing that we have limited resources at hand to actually scale these interventions that we're talking about? Thank you.
Thank you. How do we make it go around and then still focus on the vulnerable? Dr. Gaffa, I believe that's your question. Let's take all the questions together.
Good morning, everyone. My name is Rhoda Robinson, and I have just two questions. One for Dr. Ferrigero. The first is, you had talked about private sector engagement. Now, how do we go about building a business case for private sectors to invest in health insurance? Because health insurance for private sector is a business. Now we are looking at them turning this into a CSR, which is different from what they already do. Now, how do we ensure that they understand the final bottom line for building a business case for insurance? Then my second question is on the swap. And as a partner for numerous different states where we work on health, my organization works with different states on digital inclusion for healthcare, and in different over 100 facilities across, primary health facilities across different states. Now, how do we key into this, given the fact that we are in numerous states, and if we are partnering with this state and that state, and we are avoiding a duplication of efforts across the states, because different states have their different needs that we meet at the different times. Thank you.
Okay, thank you so much. There is a hand up, two more hands, but I do not think we can take it because of time. We can still meet the panelists later, please. My apologies. I believe two questions, one for Dr. Gaffa, one for Fejiro. Dr. Gaffa, please, 1 minute.
Okay, thank you very much. So with regards to the question around equity at the Agura, let me provide the context. So the last time we were told that more than 100 million Nigerians are multidimensionally poor, right? And if we have to go by poverty alone, those are the people that cannot afford health insurance themselves, and they find it difficult to pay for health out of pocket. Now, if we look at the Basic Care Provision Fund, last time I checked, and Dr. Ogbe can correct me, maybe less than 2 million Nigerians are in the pool. So more than 100 million that are needed, we have money to cover only like 2 million. So I think the big question is that how do we mobilize additional resources? It is very, very important, no matter what is the equity in 2 million, 100 million people need is only money for 2 million. So I think the big issue here is that raising additional money from various innovative sources. And I hope at the swap, we provide opportunity for partners to contribute as well, to put more money in the pool. We should not be depending on donor money. That's the truth of Nigeria. I'm saying this because I'm a Nigerian. But at the same time, if there's opportunity to mobilize our resources, we should. So I think there should be great effort around how do we mobilize money from the state, from the national, even from the local government, considering local government financial autonomy, to be able to do this. I think it's going to be very, very important. But what goes with that is the efficiency of managing even the little resources that we have. So we have to identify sources of leakages and try as much as possible put measures in place to to block them. Thank you.
Thank you so much, Dr. Gafar.
Okay, so the question, so private sector involves all the private organization and not just private health insurance firm. So when I talked about the CSRO budget, I was talking about private organizations that are not public that can contribute to health insurance. But to your question of private health insurance organization, how can they come in when they are for profit? I look at it as the way the banking sector, the financial sector works now vis-a-vis how they worked some 10, 15 years ago, where we had so many banks and split across the country and having various number of clients that they were dealing with. And then we had the CBN come and collapse them into, based on their capital. I think we need to do that for private health insurance. We need to, the government has to raise their capital to the point we will force them to merge, because again, health insurance is about pooling of funds. It's about pulling, and we have a very young demography in Nigeria, so it's actually beneficial to, we will be able to save more money. We don't have an aging population, so the dependence on insurance would not be too negative for us if we have everyone in the pool. So I think it's for the government or the agency to raise the capital such that it will force smaller health insurance organizations to merge, and then they will have a larger pool. And when there is competition, price would reduce. There will be a play of combining resources with governments, but I know that there's a lot of issue with that, where they can then cross-cuttingly either share resources with government for vulnerable population, so a percentage of the number of clients you have, you give that to vulnerable under the government scheme. How that can be worked together, but the first thing I feel like we need to do with the health insurance is to force measures to happen.
Okay, so thank you so much. That's market efficiency, commingling of funds. Thank you. Dr. Ogbe?
So very quickly on the question about swap, I think essentially, if you're an organization that works in various states supporting the health sector, if you have a national office, they can engage with the Federal Ministry of Health. There's a swap coordinating office. Just a letter to the Honorable Minister, attention swap coordinator. The letter gets there and you get pulled into the whole conversation. But if you're just working with the states are just in the process of completing their annual plans. And in this, they're also mapping all the partners working with them. So just ask your states that how far have they gone with their annual plan, and if you have been captured as part of those working with them. Once you're captured, then automatically you're in the swap pool, because you're going to be reporting on your activities and what resources you're investing in the state, and that can be viewed at the national level.
Okay.
Thank you.
Thank you. So maybe, Dr. Ogbe, just take your final words. Just give us 1 or 2 words, your final thoughts, way forward.
The way forward is for us relying more on digitization and data. Data undermines all the information we will make and all the decisions we will take to see that the vulnerable are actually targeted and benefit the most from whatever little resources we have. Thank you.
Thank you. Fejiro?
My last words will be that the world is evolving. Innovation is key. What happened, programs were initiated 2 years ago is not sufficient to solve the problem of today. Innovation with human-centered design is what we need to move the target with health insurance.
Thank you. Gafar?
Okay, thank you very much.
Yes.
So, to me, I think, in addition to the important point on the ground, I think while trying to solve Nigerian health system problem, it's very, very important to understand the whole, while fixing the part of it, and mobilize those that can help us to fix the rest of it. Thank you.
Thank you.
Yeah.
Last words.
My parting word will be on the people. As much as we are looking at innovative way of improving resources, increasing resources, we must create a system that also takes feedback from the people. We need to ensure that resources is matching with quality of service delivery. So let's create a system that collects feedback from the people and a system that works on those feedback to improve quality of care. Thank you very much.
Thank you. So, parting words from our panelists: data, digitization, innovation, a holistic approach, and focusing on the people and getting their feedback. So, ladies and gentlemen, I want to thank you so much for being such a wonderful audience, and please give our panelists a wonderful round of applause for broadening our perspective and sharing their insights. Thank you so much. I think we can just take a group picture before we go down. Thank you so much. Thank you, and do enjoy the rest of the event. Thank you.